If we solve all the problems in Medicaid, there's still going to be issues in Medicare. If we solve the issues in Medicaid and Medicare, we're still going to have issues on the private payer side. And then we're still going to have people that at the end of the day still don't have insurance.
Welcome back to another episode of the podcast for doctors by doctors. I'm Dr. Michael Jerkins, and unfortunately, I'm not joined by my co-host, Dr. Ned Palmer today, but I am joined by another doctor, because that's what we do here in this podcast. I'm very excited about our guest today because it's someone who adds a different perspective than previous guests on their deep knowledge of health policy, health economics, all these things that are very complicated and take someone smarter than me to be able to understand. So I'm very excited today to have Dr. Jeral Self as our guest. And let me give you an amazing introduction of all of the amazing work she has done. Dr. Jeral Self has more than 17 years of experience in health policy research. Much of it focused on building and using integrated data from multiple public service systems for the purpose of evaluation for various clients, including the Centers for Medicare and Medicaid Services, also known as CMS, the Assistant Secretary for Planning and Evaluation, and Arkansas and Louisiana's Medicaid programs. Dr. Self's subject matter expertise focuses on vulnerable Medicaid populations, including those receiving home and community-based services with behavioral health needs and individuals experiencing homelessness. Dr. Self currently serves as a managing director for Medicaid health policy research at the Lewin Group, in addition to her role as head of community engagement at Panacea Financial and the Panacea Financial Foundation. Also worth noting, anything that Dr. Self talks about today is not a reflection of her employer's opinions. They're only her opinions and her opinions alone. Dr. Jeral Self, pretty exciting stuff, huh?
Keeps me busy.
You have a very impressive introduction. I was like, oh my gosh, I can't believe we got you on the podcast. But can you tell us a little bit about your journey in healthcare and what first sparked your interest in the field and how you landed in this amazing role?
So growing up, I always knew I wanted to go into a profession of helping people. Growing up in Mississippi, I had a very limited view of healthcare. I thought the only way to give back was through medicine. However, through my life travels of moving different places, such as Boston, Massachusetts, I learned about other avenues of healthcare like public health. Boston is the mecca for public health services. I've also really been engaged in engineering and STEM from early on. My mom's an educator and specialized in math, so I was always engaged in math and science. So pivoting from my public health experience in Boston, I decided to go into health economics and more health policy research. And so I've been doing that, like I said, for over 17 years now, which seems crazy. I really enjoy the work, and I think that if I would have just been a physician, I would have missed out on some of the larger applications of what I get to do on the day-to-day and the impact. I appreciate the interactions that physicians have with their patients on one-on-one, but the impact that I get to have on a macro scale is really impactful. So the analysis that I do on a policy could impact hundreds and thousands of Medicaid beneficiaries versus just the one patient that as a physician I might have gotten to impact.
So let me back up a little bit. So you went to Boston to study health policy. Tell me more about that.
So I moved to Boston to do my master's in public health at Boston University. And while I was there, got to engage in various different sectors. So I worked as a research assistant and later research director on a clinical diabetes study. I also got to intern at the Massachusetts Department of Health with various entities, their impactful system, not only on the various hospital networks that they have in Boston, but also within their community resources. As Boston has a lot of community health clinics that do a lot of impactful work with their Department of Health. And then last but not least, that kind of spurred my desire to further my schooling in that area. So ironically, at first, I thought I wanted to do social epidemiology, understanding that those social and clinical factors impact people's outcomes, and thus through social epidemiology, you could study that. But one of my professors told me after I took a test one day that the analytical thought process that I had was more of a health economic researcher than a social epidemiologist. And at that point, not really knowing the ins and outs of health economics, I was like, I don't know if you're right. So decided to take a step back before going into school and come and work in the field for a little bit. And through the work that I did when I came to Arkansas, on the Arkansas Section 1115, now it's known as Our Home expansion that Arkansas had, I got to get my feet wet in data analysis and economic modeling and evaluation, and really fell in love with those passions. And that teacher was actually right. Health economics, health policy research was more the route for me based on those skill sets. And I will never regret that recommendation because I truly enjoy the work that I do on the day-to-day. My husband jokes with me all the time. Most people dread going to work on Mondays, but I actually enjoy it because I really enjoy the work that I do.
Man, so that professor made a big impact on you, and then downstream, thousands and thousands of patients. That's pretty cool. Have you talked to this professor and said, hey?
Sadly, he passed away, but I'm in touch with his family, but sadly he did pass away.
I'm sure he had lots of impact on lots of students.
On various students.
That's amazing. I want to touch on this later, but I think it's so interesting that your point earlier on how you have an ability to make an impact on hundreds and thousands. When I see a patient, I see one patient, I see their family. So maybe you can count, a few extra. But to your point, like it's hard to scale that effort, whereas you're saying, hey, I can make some recommendations, form programs, and really benefit thousands, especially on the Medicaid side. Was there a pivotal experience that really shifted your focus towards Medicaid specifically in those populations?
So I think growing up in Mississippi, Medicaid is the biggest insurer of individuals there. So understanding that was the way that a lot of people in my state were accessing care, I always had an interest in Medicaid. I think that knowing the passion that I had for certain communities and my expertise in certain communities, it then overlapped that those communities were best served or were currently being served through Medicaid. And it kind of came full circle. So that intersectionality of my desire to want to work with maternal health individuals, those with behavioral health needs, and Medicaid being the largest payer for that group, as well as, like I said, the understanding from growing up in Mississippi, which is a huge Medicaid managed care state, and seeing that the means that individuals are using to receive care kind of connected the two. And then I would say like the biggest thing that set me on the trajectory of Medicaid was coming here to Arkansas to work on that evaluation and learning more the nuances of the Medicaid policy. The joke that we all use of everybody that works in Medicaid is, one Medicaid program, one Medicaid program, because each state's program is so nuanced and different. And I think the engagement of that nuance and different sparked my curiosity to then know that it's not the same day to day when you work with different states. Their populations are so different. The needs of those populations are so different. The policymakers you're working with are so different that the variation that you get to have is so enjoyable for me from an analytics standpoint. So that kind of is how it all came together.
I can see now that what your professor saw, you talk about analyzing Medicaid data, you kind of brighten up and start to smile. So clearly you really like what you're doing, and I'm thankful for that.
I think it's important as health researchers, as health economists, to understand that the numbers we run are not just numbers, they're people. These individuals have stories, they have needs, they have families, like you said. And so what we're doing holds some accountability for where directions of their healthcare takes. And I think knowing that the numbers I'm running are like the story of people, really engage me and really makes me strive to be the best health economist, health researcher I can be.
I think this would be a good opportunity for you to educate our doctor listeners on some things about Medicaid. So now that you've worked so closely, have so much experience in Medicaid and the physicians that are delivering care and the other providers, what do you think most people misunderstand about Medicaid and its role in general in our U.S. healthcare system?
I think there are several things that are misconceptions about Medicaid. I think one is that people on Medicaid are not working individuals. If you look at the vast amount of individuals who are on Medicaid, they're single mothers who are working 3 jobs and need insurance to help support their children. They are individuals that are transitioning from different school programs that have been off their parents' insurance, that don't have opportunities for insurance under other umbrellas. I say that Medicaid is the filler for transitions in people's lives to help provide them with healthcare support. And I think that is one huge misconception of the Medicaid population. It's just people sitting at home, not working.
And not to mention the amount of children on Medicaid.
Exactly. The other misconception I think that people have of Medicaid is that, it's just this huge pot of free money. Actually, Medicaid eligibility processes and determinations are extremely stringent. It is very hard not only for somebody to get on Medicaid coverage, but to keep Medicaid coverage. So the whole point that everybody's just getting this pot of free money so easily is very untrue. And then on the other side of it, from the physician standpoint, the requirements of physicians to bill under Medicaid to keep their criteria as a Medicaid eligible provider is also very stringent. So the stringencies in getting in the door to either have Medicaid or see Medicaid patients, as well as keep that coverage or continue to see Medicaid patients, is very stringent. And then I think the last thing that is a huge misconception about Medicaid is, like I said, one state Medicaid program, one state Medicaid program, that everybody in Medicaid is the same, which is so not true. You look at the variety of recipients in states, so looking at those that are largely rural versus those that are urban, looking at those where the majority of your population are more children than working age individuals, and making sure that the policy needs really align to those individuals. I think people discount that nuance and thus don't understand from a policy perspective why we just can't have a blanketed response to delivering public insurance through Medicaid. In working it over the years, those are the three biggest misconceptions I think people have about Medicaid.
That makes a lot of sense. It's hard too, because doctors have in the weeds, just the day-to-day, and sometimes hard for us to really understand what the population knows and doesn't know about how we engage as doctors and how patients engage with healthcare and the different systems. So that's really helpful, I think. And also, I've only worked, I think, in 3 states in their Medicaid programs, and they're all 3 very different, just like you said, 3 very distinctly different. No, there's so much innovation, I feel and especially in the last couple of decades in healthcare, and sometimes it's cyclical. We think one thing works and it doesn't, and we try something else and we go back to the first thing. Walk us through maybe some innovations you think and you've seen in your experience in healthcare that actually deliver better patient outcomes and better care.
So I will say that even though COVID had its impacts on our country, from the medical perspective, it really opened a lot of doors for some really effective evidence-based practices to get reimbursed through policy. One of those largely is telehealth. So for a lot of continuity of care in the patient base, especially in rural communities or underserved communities, where getting to a doctor's office is very hard. The reimbursement of telehealth, not only by Medicaid and Medicare through the COVID PhD, really did open a lot of doors for individuals, particularly those with unmet behavioral health needs, to get those needs met. And I think the continuation of some of those policies after the PhD has really helped from the continuity of care aspect and the undiagnosed conditions that a lot of Americans had during that time. I think another innovation within the field really has been understanding that if people have healthcare and understand how to use it, that then we will see better outcomes. I think a lot of states passing legislation to allow certain populations, pregnant women, to have extended continuity of care after delivery have been key to help from a continuity of care and access issue. I think another innovation that has been really helpful in the behavioral health field is the expansion of the flexibilities of prescribing practices, as well as on the behavioral health forefront, a lot of school-based health initiatives. So understanding that our children spend most of their day at school, why not have social care entities, behavioral health therapists, speech pathologists, all of those things in a school-based health care setting, and reimburse for those services in that setting, knowing that when kids leave school, they're not going to those appointments, and like we see better outcomes from there. So I think we talked about this early on, like understanding that doctors in the office can only do so much. I think expanding the dimensions that we can offer coverage and access to individuals outside of the office has been really key since the PhD, and I think will continue to be novel as we want to increase delivery of these services to populations.
I love that. I, as someone who's worked in a school-based health setting, multiple school-based health settings, it's near and dear to my heart. Totally agree. It's bringing the care to where the patients are instead of expecting them to come find us, especially when it might be hard to access transportation and things like that. And the great models, I think, in school-based health, like you said, and I've worked in these, have dental care, medical care, eye care, as in being able to do free vision checks and glasses and social work and mental health, all in the schools and the public health systems. And there's several, I think, instances, or I should say, examples of it across the country that serve as models. But like you said, maybe some states Medicaid won't really work with the school-based health clinics, whereas others are more open to that.
And I think it comes down to like where priorities lie, understanding that every state can't do everything because they can't. I think it's where the priorities lie, as well as like where you have budget flexibilities to do those things. Understanding to like change Medicaid policy, and that's another thing that's a misconception, is that to change a lot of Medicaid policy, especially from a financing standpoint, it doesn't happen at the national government level. It happens at the state level. And states only have legislative sessions X amount of time of the year. So if it's not prioritized to go through that session at that time, to then have funding allocated to it, a lot of times people are like, well, why hasn't this happened within the last year? And like it happened in all these other states. It was voted on in their legislative session versus our states. And so that's why it was not determined. And so I think that's also too where people, and where I feel we'll get to conversations about advocacy. Advocacy does have to come early on from a priority standpoint to then make sure it's on the docket to potentially be discussed and funded through various policy initiatives at legislative sessions.
And so I want to back up real quick. I want to hit on this in a second, but you talked about telehealth as an innovation. And my understanding, and correct me if I'm wrong, is that we had a lot of telehealth come into play, especially in COVID, and I delivered care through telehealth, is that a lot of insurances are no longer reimbursing the levels they did, or maybe at all, for telehealth. Is that true?
So that is correct. But reimbursement across the board has always been an issue, especially with Medicaid. So I feel like a struggle, and this is analysis that I work with a lot of states on, are what are the ranges, understanding that you can't give every physician the same number based on their specialty or experience, but what are the ranges that really are going to incentivize doctors to expand their Medicaid patient panel for X, Y, and Z reason? I think a lot of states struggle with this because sometimes based on our analysis, like the ranges are too high based on their budgets. So if you can't then do that for in-person care, where can you move the needle from a reimbursement aspect in other areas? Telehealth was one of those. But then to your point, a lot of federal mandates came down that then the reimbursement needed to go down. So then if the reimbursement has to go down there, where else can you then incentivize providers? Well, patient-centered medical homes have always taken the approach of giving like a case management or other fee of like $15 to $30 to incentivize doctors to keep certain patients on their panel. So thus some states have taken that approach with like incentivizing additional care through case care coordination fees. I think at the end of the day, you have to be very flexible when it comes to various reimbursement mechanisms, knowing that like, yes, you create something and it works for a little bit, but then either a policy shift happens, the needs of the patients shift in a provider's panel, et cetera. And so you have to be flexible there. So in the case of the decrease in telehealth, thus other states have rotated with other different types of incentive mechanisms to try to keep providers to keep these patients on their panels.
The thing that people talk about now is, of course, and you hit on this with telehealth really being a great tool to reach the patients that live in rural areas. And as we know, a lot of the rural hospitals Many have closed. Some are kind of in the financial limbo. Talk a little bit about the rural hospital and how we should think about that, especially in light of potential decrease in funding to these hospitals.
I think it's important to understand that rural hospitals are not just funded through their Medicaid base. They get other incentives through dish payments, uncompensated care, et cetera. But understand that the people within those communities are largely Medicaid recipients. Thus, you're increasing the likelihood that when somebody comes to those entities for care, that they have no types of insurance. And that really is a struggle, especially because those rural hospitals are in lower settings. I think thinking about the fact that when it comes to hospitals, it's not always a one-stop shop, though through policy we try to do our best to have certain safety net hospital tracks and different things to provide services there. At the end of the day, looking at the increase of closures in certain rural hospitals, what we're doing there isn't necessarily working. And so I do think we do need to level set in a lot of those communities to really figure out from a sustainability standpoint how to best support them. Because it might not all come through policy and funding. There could be other initiatives needed within those areas to do that. But I think without more of an extensive assessment of those closures or evaluation of those closures, we won't pass reimbursement what's needed in those communities.
And to even get the providers there, right?
Exactly.
There's some that think there's a doctor shortage, and there's numbers that can back that up. And there's others that say, we actually have enough providers, they just aren't in the right places. Right. Then you don't have a place to practice in these rural settings because the funding decreased or insurance mix changed, then it just exacerbates that problem, potentially even more. And I think it'll be interesting to see how that plays out, hopefully in a good way. You've hit on this a couple of times because you talked about state legislatures. So they have legislative sessions and there are various times, and sometimes they're very small, actually, depending on the state. How do you advise doctors? What advice do you have for doctors on advocacy? I mean, clearly there's the large doctor associations, state, local associations, which I think are great and advocate on behalf of doctors, but what would you advise doctors? You know so much now about policy and how it all works. I feel like a lot of us as doctors don't really have a chance to look up and out. We're always head down patient care. What can we do? What advice do you have for us?
So I think understanding that physicians have competing priorities and the first priority is their patient, advocacy can be very hard. Past the engagements in the national groups and actually vocalizing to your representatives of the national groups where the priority needs are, I think there are two other avenues that providers could do from an advocacy standpoint. What we've seen from the insurance sector is there's been a lot of movement on more patient satisfaction of care and innovation that providers are doing within patient satisfaction of care that provider bases have been doing from an advocacy standpoint to get certain insurers to reimburse for. So I think if you're doing something novel in your practice that really is getting uptake, not only speaking to your billing specialist that you work with to then circle back to the higher insurance to then speak to those things, also through your advocacy group, you could speak to some of those initiatives to hopefully get them escalated to a national scale. I think outside of that as well, so taking that approach to what's working in your clinic and advocating for it, I think it's important to understand, and I know that providers don't have time for it all the time, is if they feel like evidence-based practices that are being reimbursed are counterintuitive to where they're seeing success, researchers do the work, but the physicians are the ones in the day-to-day. So if those evidence-based practices are contradictory to where you're seeing success, I think it's also important to either, reach out to those researchers to have those discussions, as well as, like I said, escalate what is working to the national platform, either through your advocacy groups, through your state groups, et cetera, to then get it on a larger scale. I think understanding that you are one of many and understanding that others probably are having the same issue as you, but you don't have enough time to come together to discuss it. I think finding avenues to elevate it to a larger scale for feedback across a bigger group from a policy standpoint will help, as I feel like sometimes when policymakers see it more nuanced. So like, oh, it's just like 1 or 2 providers versus like it's 80% of the OBGYNs in the nation are having this issue. I feel like then it moves the needle as more of an urgent policy need.
Yeah, and I have these discussions with the large associations, even state and county associations, both dental, medical, vet. And unfortunately, they see a declining in membership of the early career doctors.
Yeah.
And I think a lot of it is because the early career doctors aren't quite sure, or it's not as visible the work that these entities do. And maybe there's been failings in the past that have been not satisfactory. But at the end of the day, like you said, you're just one. And you spoke to this too, like the power of being organized and having some advocacy, the numbers really matter. Yeah. And I had someone say to me recently on the association piece, like, you reduce the association, think of it as vocational insurance. Like you have life insurance, malpractice insurance, but this is like vocation. This is helping your vocation. And obviously we're very biased on protecting how doctors practice because we think that's in the best interest of the patients. That was my soapbox. I'll step off of it, I guess, for a second. But thank you for letting me have that diatribe. I'm curious on your, and maybe even not just Medicaid, but zooming out in U.S. healthcare in general, what do you think the most pressing issue is in healthcare right now in the United States?
So I feel like the most pressing issue in healthcare right now is we took a lot of leaps forward, but I feel like we've gone 15 steps back. In the trajectory of many patient bases that are receiving healthcare. Let's take maternal and child health, for example. We have some of the, compared to our foreign counterparts, have very morbid health outcomes when it comes to maternal and child health in this country. However, until recently, we've not reprioritized initiatives that then focus on those outcomes. And so I think it's very struggling where like we make progress in certain areas, remove things that either from evidence we know are working and practices where we're seeing success due to budgetary cuts or budgetary restraints to then go back to where we were 10 years prior. And I think it goes back to like our viewpoint on certain things. I think sometimes because it has a higher price point, we look at it as an inefficiency versus looking at like the larger continuum of care of where we're seeing success. And I do think that that's an issue in our system. I think the other thing is understanding there's not going to be like a one-stop shop that fixes all of our problems. So if we solve all the problems in Medicaid, there's still going to be issues in Medicare. If we solve the issues in Medicaid and Medicare, we're still going to have issues on the private payer side. And then we're still going to have people that at the end of the day still don't have insurance and thus have to find different means for the providers that deliver that care to reimburse them in some way. And I think that with each changing of administration, they take a different prioritization of where they feel like the problem is and how they can solve it. But I think until there is a more coordinated approach across all the various insurers and entities, we're not going to solve all of the issues because when we solve them in one payer, it's going to cause others to spur in another.
To your point, everyone wants to fix healthcare, but it's not like, and it's funny because I'm about to ask you a question that is contrary to what I just said, but it's really difficult to just fix it all with one fell swoop. But let's just play this out. If you did have a magic wand that could fix at least one thing in healthcare and you could do it today, what would that thing be that you would try to fix?
I think coverage and access, like we talked about, is a huge issue because we know that if people have insurance and they understand how to use that insurance, it empowers them and we see better health outcomes. So I think not only ensuring that people can stay insured, but literacy on what being insured means. It's crazy the amount of conversations I had, even with my family, about like the difference between coinsurance and deductibles and who's in network versus who's out of network. And again, I do this on the day-to-day. So for me, it seemed basic. But for other people, it really is a challenge to using the insurance that they have. So I think it is more than just giving somebody access. You have to teach them how to use that access. And I think incentivizing insurers, whether that be Medicaid, Medicare, or private coverage, to have that literacy piece is key. And that's something I think, again, it's not going to solve all our issues, but I think would help with a lot of the faulties we're seeing in this system of people misusing the access they have.
Interesting. And my understanding is actually a lot of recent, at least, increase in the dental spaces for our dental audience has come from government insurance, so Medicaid and Medicare. Can you educate us on how Medicaid specifically, or even Medicare, engages with the dental market and helping patients access dental care?
So I can speak to the child chip expansion because I know quite a bit about that. I will say, based on the research, we always knew that like dental health for children was key to their growth and development, but there was a lot of variation in terms of state practices for reimbursement, as well as there's a lot of parents that have access to insurance for their children, but the dental portion wasn't offered. So using Medicare as a mechanism to supplement that. And so a lot of states have taken strides to expand that accessibility, knowing the importance is there. I will say, however, that a lot of the same hoops we talked about for dentists getting Medicaid accreditation and then also being able to keep that is a very struggle, just like it is for physicians. So I think to then ensure the continuity of that care for the patient base as a whole, Medicaid should consider some of those policy constraints to then incentivize more dental providers to participate. Because when you look at the network of dental available providers versus the network of pediatrician or other child specialists, it is rather low in proportion in states that have dental coverage expansively for children versus, other professions.
As a doctor and a pediatrician, there's a lot of patients I see that then don't have any access to a dentist. And at least in the state and some other states, it seems like the private practice dentist, is, like you said, it's tough to maintain the accreditation and the reimbursements aren't quite as high and their costs are going up on the private practice side. At least it seems to me, the organizations that can really deliver dental care with Medicaid reimbursement are the large groups, the large DSOs and entities that have scale. They have groups that can help with the paperwork, and the less reimbursement doesn't matter because they have just tons and tons of patients.
But then we speak to the fact that, like we talked about, like underserved communities, though, like rural communities, like you struggle to have just enough basic provider, like basic physicians, let alone dentists. So like then in those communities, how can Medicaid help support that dental care? Some states have taken in those communities to doing more mobile dentist visits and like then incentivizing that as an option for reimbursement versus having to go into a dental office. Also too, dental is an area where Medicaid and a lot of Indian health services have come together, understanding that under tribal health, like dental needs are high as well. So like in those areas that correspond to those rural communities, how to then team up with IHS to then administer those services. And so I think, like we've talked about, from a reimbursement as well as access standpoint, we have to be a little more inventive of how we're trying to get beneficiaries to access this care. Because to your point, for whatever reason, they can't get to certain offices, they can't get appointments, X, Y, and Z. So understanding that those barriers are going to be in place, how then can you create other opportunities and other incentives for providers to then deliver that care through other avenues?
Makes sense. Well, in intro, we talked about all of your accolades, but one of those was also your work with the Panacea Financial Foundation. Can you tell us what this foundation is and why it exists?
Okay. Yes, I can.
I kind of already know the answer to this, of course, but I want to make sure our audience knows it too.
That's fair. The Panacea Financial Foundation was created to address the underrepresented minority pipeline in medicine, understanding that through the foundation, we can't patch all the leaks in the pipeline. We do focus on it in 3 different areas. The first being providing financial literacy and educational opportunities for students, residents, and fellows in training. Additionally, we administer grants and scholarships to students, residents, and fellows. And last but not least, we are building a mentor-mentee network, understanding that it's very important for these aspiring physicians to have somebody as a sounding board who can relate to them, that they can see success in their specialty and somebody who looks like them, understanding that that is key in these 3 areas to their growth and development as successful physicians.
And at this point, there's been several $100,000s of these grants and scholarships, which is pretty cool, tooting the foundation's horn a little bit. And I know we've talked about this already today in another matter, but what are some unique ways you've seen people actually use the grant money on the resident and fellow side?
Understanding we provide an avenue for fellows, whereas a lot of funding is focused on scholarship. The grants are very unique, and the purposes we see across the application for the use of those grants have been unique. People have used it to go back to their home countries, whether that be Costa Rica, the Dominican Republic, various facets of Africa, to serve their communities in areas of medicine that there are no providers there. We've seen from an educational literacy standpoint, people use it to fund children's books for children in inner city communities, to see examples of brown and black doctors because those are not in their communities. We've also seen other opportunities understanding the priority of the engagement of clinical research as well as practice-based research within our awardees who have a passion in that area, to use the funds to fund their research, to study conditions and diagnoses that are relevant in other represented communities. So across the board, we see very unique opportunities, but those are just a few to highlight from our most recent applications.
It's pretty crazy. I say this all the time because, I do see some of the applications and I see the CVs, I see the essays, and a lot of these people already have a not-for-profit. They're themselves set up and are working on while they're in training. Either way, I look at these applications and I'm amazed that I even got into medical school, quite frankly. And it's so impressive, I think, the work the foundation has done to support this future and current generation of leaders. In fact, some of those previous winners are now on the board, which is pretty cool, and continue to give back.
And I think to your point, with the rise of applications that we continue to see across the cycle, it speaks to there is this need and that we're trying to address it in the best way we can.
Love it. I have a couple of rapid fire true, false. I'll say a statement and you basically tell me if you think it's true or if it's false. Okay. And I don't think I prepped you on these, so this is gonna be fun.
Okay.
Some are not related to healthcare, just stream of consciousness.
Okay.
But true or false, AI will make us healthier as a population?
False.
And why do you think that's?
I think because AI is only as good as the information that's put into it. I think there are areas of healthcare and research that we've only scratched the surface of what the underlying causes of them are or where the diagnosis needs are, that I think if we just go to AI as the one-stop shop of truth, we will miss the mark on those things. So I think in areas of medicine and research that are more fully developed, where we have a stern evidence body of research to feed into AI, I think it could be great. But I think in those areas where they're not, or populations that are not well studied in certain communities, it will be a detriment to use AI as the truth of healthcare resources for those communities.
Do people use it now, I guess, a lot in the research side, just data analysis and?
So people do use it in the resource sides, but I will say in a couple of recent proposals that I've worked on for various government entities, they've been very explicit about cautioning people to use AI for streams of work that they feel like there needs to be more critical thinking and involvement. I think everybody recognizes the advantage of AI as a management tool, as an administrative tool, or like I said, in those areas that are more fully thought out. But in those that aren't, or those that require more critical thinking, even these government entities are very clear, please do not use AI for these purposes.
And it hallucinates, so it just makes up things as it goes. Interesting. True or false, access to healthcare will improve over the next 5 years?
False.
Okay, and why do you think? I love this. I love that. That was a long, thoughtful pause. Why do you think that's false?
Because if you look at the enrollment trends, because this is the economist to me, so I look at enrollment, I look at inflation factors, I look at trends over time. If you look at the enrollment trends of insurability of where we're estimating them to go, we will probably see a decrease over the next 2 to 3 years before we see an increase. There's a combination of factors including that. So some of them are related to inflation, some of them are related to the birth rate in the country. So there's various factors that feed that, but based on the numbers we're seeing, we're estimating a slight decrease to then have an increase probably 4 years out.
Interesting. Okay. A very nuanced answer. I love it. On a similar note, true or false, healthcare costs will continue to increase over time.
True. I think understanding that we're trying to make budgetary restrictions that will help cut costs, I don't think those restrictions are going to make us more efficient, which overall over time will result in increased costs overall.
Coke versus Pepsi. So that's not really a true or false question, is it? Let me say this. True or false, Coke is better than Pepsi?
I'm a Topo Chico girl, so
is that neither?
It's neither for me.
We are not sponsored by any of those manufacturers, for the record.
Coke did buy Topo Chico, though.
Oh, it did? Okay,
yeah,
so then
Coke. I'm a
Coke.
Topo Chico girl.
Okay, wow.
Yeah.
Well, there you go. There's the truth. I had no idea. Okay, we always finish the podcast with asking every single guest the same question.
Okay.
I'm going to ask you the same question. And I ask it because it's so interesting to me that we have never had access to more information. We never consume more information than we have today. But when does it actually affect our opinion? This is fascinating to me. So my question is, what is one thing that you've recently changed your mind about?
As a new mother, I used to think when my mom would always say like, oh, mom brain, oh this, oh that she was just making up because she just didn't want to, whatever. I think that mom brain is a real thing. And so that is something that with my daughter, I've completely changed my mind on.
Have you called your mom and say, hey,
yeah,
I get it now?
Yeah, I get it now. I get it now.
Well, this has been awesome. Dr. Jeral Self, thank you for joining us on the podcast and educating us and hearing more about your story. This is fascinating. So thank you so much for your time.
All right. Thank you, Michael.
Thanks for joining us this episode. And you can catch the podcast for Doctors by Doctors on Apple, Spotify, YouTube, and all the other major podcasting platforms. If you enjoyed this episode or learned anything here today, please take a moment to give us a rating and subscribe so that you don't miss a single episode release. To submit topic suggestions or guest suggestions or questions, you can reach us at podcast@panaceafinancial.com. As always, thanks for listening. And the next time you see a doctor, maybe you should prescribe them this podcast. See you next time.